Welcome, everyone, to this special International Academy for Clinical Hematology Journal Club webinar and roundtable discussion. It is 6 p.m. in Paris, noon in Montreal, 11 a.m. in Houston, and today we are focusing on a rapidly evolving and highly practical topic: how to establish an outpatient program for delivery of bispecific antibodies in multiple myeloma. I don't need to spend a lot of time to convince this audience that bispecific antibodies are increasingly integrated into the treatment landscape for multiple myeloma, and there is definitely a growing need to adapt our clinical infrastructures to deliver these therapies safely but also efficiently, particularly in the outpatient setting. And this transition would bring opportunities for improved patient experience and optimized healthcare resource utilization, but also it comes with logistical, clinical, and organizational challenge. This is why we're very fortunate that we are joined today by two leading experts, namely Dr. Christine Ye from MD Anderson in Houston and Dr. Jean-Sébastien Claveau from Canada. And actually, the Scientific Steering Committee of the IACH was the initiative of this webinar was triggered actually by this review article published in Care and Oncology, I think at the end of April, and the senior author is indeed Dr. Claveau. And here in this paper, the Canadian colleagues from different centers, and this is really important to have like the global perspective, described their perspectives on outpatient delivery of bispecific T cells. And in the article, and that's going to be my only slide, there is this very nice figure, very schematic about actually the different requirements for the outpatient delivery of T cell engagers or bispecific. And this is about organization and legislation, depending on your environment, the patient and caregiver requirements, the operational procedures, the nursing aspects, and last but not least, the educational aspects. And addressing, of course, all of these delivery challenges requires careful planning and adequate resource allocation to ensure such safe and efficient therapy delivery to all eligible patients. So I'll stop here, and a very warm welcome to all of you. Thank you, Jean-Sébastien. Thank you, Christine, for joining us. I know both of you are in the middle of your clinic, so we're going to try to be straightforward and to the point. And I think what's really interesting among both of you is that Jean-Sébastien, you have, I think, already established such program. And while you, Christine, you have the CAR T-cell outpatient program at MD Anderson, and you are transitioning now to the bispecific outpatient CAR T-cell. So it would be very nice to have these both visions. So Jean-Sébastien, please tell us more about the story, how it happened in the different Canadian centers.
So thank you very much, Dr. Moti, for the invitations. So I think the issue in Canada is that we don't have enough bed to admit every patient, especially for elective treatment. And it's pretty an issue with all our new treatment available in myeloma with bispecific and also with CAR Ts. we have shortage of nurse that are doing that. We have some beds that are just empty, and we are not able to admit some patients to start a treatment, to start a bispecific. So it was like close to 9 months ago that we start our first patients receiving teclistamab for myeloma in our outpatient clinics. So what we did is that the patients at the beginning was seen 3 times on the weeks, on the Monday, Wednesday, and Friday. He had blood tests on that time, and after that he was receiving his teclistamab and was going back at his home. We are also doing phone and video call with them to be sure that everything is fine and that no serious, no ICANS, no neurotoxicity happens. So, and the first patient, it was me and one of our nurses that were calling the patients to see that if everything was going well. Because if we were not doing that, the patients will wait some things like 1 month and even 2 months before being able to be admitted and starting the bispecific. And it's pretty an issue with myeloma because we know that more we wait, more the M spike will be high and more the response to the bispecific, it's not always perfect. And it's more difficult. And we have some patients that just waiting the time to have a bed that goes had renal failure, some had bone lesions. So I was not comfortable as physicians to just wait to have a bed. So it's like that we start to do the step up dose in our outpatient clinics.
Excellent. Thank you very much. So now my question to you, Christine. I think we heard about why this was needed. And how is it in Houston at Emory Anderson? Why do you believe you need to establish this outpatient? And maybe you can share already your experience with the CAR T cell outpatient, because we're talking about actually, at the end of the day, outpatient delivery of immune therapies.
Yeah, sure. Thank you, Professor Modi, for the invitation, being part of this discussion. And certainly, this is a very timely topic for the immunotherapy in multiple myeloma management. And I think I agree with Dr. Cabo that the resource utilization is very important. We have limited resource for all the patients, and we should be strategically planning how to utilize our inpatient beds and how we can optimize. One is not to compromise the safety outcome, and at the same time to better utilize the resource. So I think to keep that in balance, our CAR T service, we've been doing outpatient for a while, and it's running more and more smooth, in the outpatient setting. And I feel like initially patients were scared and they felt more secure in the hospital, but now they feel like, yeah, this is feasible. And some of them really like it. They can stay in the hotel or in their home and monitor the red flags that they were educated for, and then communicate with the CAR T clinic, for example, and they go there every day after the infusion. So I think very similarly for bispecifics, what we have to pay attention to is how to select the right patient. Not every patient is a good candidate for the outpatient. So for example, we do look at like a history of CRS and ICANS if they have received any immunotherapy in the past. And the disease burden is important. If they have like a very rapidly, like a doubling time of the biochemical markers, and also EMDs or like plasma cell leukemias, maybe those patients are not a great candidate for outpatient. And some of the comorbidities, those are important for us to know. patients on dialysis, heart failure, AFib, and cognitive impairments. Those are the things we need to keep in mind, whether or not this is a good candidate for outpatient treatment. And also, equally important is the social status and the support from their family, because we do require those patients to have the lodging within an hour from the hospital, and also 24/7 support from the family member. If this is not feasible, then we probably could not safely deliver outpatient treatment. So I think on top of that, a very quick and efficient escalation pathway is very important, because if anything happens, we have to give patient instructions and how to quickly transition from inpatient to from outpatient to inpatient. And certainly different hospital may have different infrastructures to deal with that. I communicated with different institutions, my colleagues from different hospitals. Sometimes they have a step down ICU unit. Sometimes they have a between ER and inpatient. And some people just send the patient to ER. Some hospitals, they do direct admission to the hospital. So there are different infrastructures like the setup to fulfill this criteria of quick escalation pathway, so that patients can be taken care of once that needs arise.
Wonderful. Thank you very much for sharing your own experience. So, Jean-Sébastien, let me ask you a practical question because you're doing it. What is your SOP when it comes to eligibility criteria? Christine alluded to psychological and social assessment, but also the role of caregivers and maybe whatever geographical challenges. So what are your exact criteria when you decide for a given patient to go into outpatient delivery of bispecifics?
The first thing that we look is the caregiver. That's sometimes the biggest issue. I mean, because the patients need to stay with someone, with a relative, for at least something like 7 to 10 days to just have monitoring. Also, the patients need to take his vital sign. He need to do the I score. So many times he needs to have someone close with him that can help to do all this monitoring. So that's the first thing that we ask. That's the most important things, because if something is not going well at home, they need to be able to come back at the hospital, and we need to have someone with them. So it's really the first thing that we look. And sometimes it's really difficult because we have patients really fit that are eligible for everything, but they are alone, they don't have friends, they don't have really close family. So that's can be really sometimes an issue. And yeah, so
in your experience, having a reliable caregiver and I would say imagine a transportation plan is a crucial parameter
exactly, to
for
be
the
able,
success.
yeah, so that's the first thing that we look for. Bispecific, in contrast with CAR-T, we accept that even if the patient is progressing really rapidly, even if they had extramedullary disease or even plasma cell leukemia, we did some patients with all these high risk
so you are more
disease.
liberal actually when it comes to disease burden than with CAR T-cell.
Yeah, exactly, because the incidence of CRS is really lower, and it's the same thing with neurotoxicity. And we are really proactive that if the patient, for example, is doing 38 of fever at home, we are already asking them to take dexamethasone. And so we are really proactive on this way to manage anything that can happen during the step-up dose.
And I think, of course, all of us would agree on this because the 4 bispecific antibodies that are already approved by different regulatory authorities worldwide, namely the anti-BCMA1 teclistamab, elranatamab, and linvoseltamab, but also the anti-GPRC5D, namely talquetamab, have been shown to be to having a relatively high incidence of CRS, but this is mainly grade 1 and 2, and almost inexistent or very, very rare neurotoxicity, which is quite reassuring. Christine, can I ask you a question about, because the physicians have selected the patient, they tick the criteria. How would you envision the nursing and the coordination of care? Because it's not only about the doctors, but we need, the whole other healthcare professionals, the nurses, but also the pharmacist for delivery of the drug, and how this handled in your environment.
Yeah, so this is crucial as infrastructure to build this outpatient management of the immunotherapy. And we do have this team. We actually have a lot of we call APP, advanced nursing practitioners or physician assistants. They actually can see those patients routinely in the CAR T clinic or immunotherapy clinic. And our nursing certainly does a lot of like education, and our PharmDs, they actually help to set up this infrastructure and give like a patient education as well. So with this teamwork, it is like a platform you set up, and everybody plays the important role. And the nursing, when they assess, I know like we are about to launch the outpatient bispecific program, but including Dr. Clavo's hospital in Montreal, and also there are publications from, for example, Emory. They had a very nice publication, and also Mayo Clinic. They actually had a couple of nice publications as well. Very nicely, showed from the initial clinical trial, because teclistamab is the first in class approved for by FDA for real world use. So that's why we have more data coming from teclistamab. In the initial Majestic trial, the CRS was reported around 60 to 70%. Interestingly, with all the good measures like of course, there are like it's multifactorial patient selection, like education, and sometimes like prophylactic medications. And the CRS in the real world was reported around 30 to even sometimes lower, according to one of the Majestic subcohort. Only 27% of the CRS as outpatient with the TOC prophylactic use. So those are all encouraging data to help us to set up a plan how to work with pharmacy, with nursing to do the outpatient management.
So here we have one question from the audience for you, Jean-Sébastien. Are you using tocilizumab prophylactically to everybody, or dexamethasone? Or we have another remark from a colleague saying, oh, we do it, but we give them a pill of dexamethasone just in case. And then the other question we have, and both of you can think, is there any role for telemedicine in this outpatient program?
Yes. So yes, we give dexamethasone just in case that some things happen. So patients all have dexamethasone that they don't take, except if we ask them to do it. Yes, we are using also prophylactic tocilizumab, especially in patients with high-risk disease, patients with that their M spike is high. We are also using prophylactic tocilizumab, and we already have some study that it showed that it's really decreasing the incidence of CRS. So that can be an useful things to do to prevent admissions of these patients that are receiving bispecific in outpatients clinic. That's the first thing. For the telemedicine, yes, we are also using telemedicine. So in the eligibility criteria, that's the second thing that we look. We give to the patients and iPads, so we can do video call with them. And they also have a device to take the blood pressure and to take the blood saturations and also the temperature. And we have on net we have access to indirect to all the result of the vital sign with these device that we use. So that's really helpful, because if the patient is doing fever, in few seconds after they take his temperature, we already know that we need to do something, and we receive um, an alert by texto on our cell phone telling us that these patients is doing fever. So that's something more of security that we use, but that also it's really important for the patients, and they know that we know what is happening even if we are not close to them, if they are not in an hospital bed.
Excellent. Thank you very much. Christine, how is it on your side? And one practical question, I don't know if there is a right or wrong answer from the audience also. How many nurses for how many patients each week? I don't know if we know the answer for this.
Well, yeah, for bispecific, we haven't started yet. So that's why I'm sorry I don't have the figure for you. But we, for each clinic, yeah, I'm sorry that I don't have that particular cut. I can speak for like a regular like a myeloma clinic, but not the immunotherapy clinic. But I do agree with Dr. Clavel, like those two aspects Professor Modi already mentioned, like the pre-medications and also like monitoring, right? These two hand in hand. And I think so in US NCCN guideline already approved TOSI as the prophylactic medication, in addition to like usually we use Tylenol, Benadryl as the prophylactic medication. And dexamethasone, I know some of the centers considering anywhere between 10 to 20 milligrams, and this is like what it has been used for. And the portable medical devices, it has become more and more popular because there are so many people, they have like Apple Watch or different like devices. So this is something I think is a learning curve. Some of the centers, they started to use that, but who will process those data received from the patient. And I think like some of the centers, they started to use nursing to monitor those, and also like the intervals. You can set up the intervals for those vital signs to be taken, and then see how the nursing would instruct the patients. Because some of the centers, for example, in Emory, from their published data, they actually, once there is alert received, suspicion for CRS, they actually instruct the patient to take the dexamethasone, Tylenol, and Benadryl as the rescue medication, and then instruct the patient to come to the hospital. So I think those are like technology is also helping us to make this outpatient management feasible.
Actually, Christine, you already almost responded to a remark of a question from Dr. Otili Lakota about telemetry monitoring or independent vital sign recording, exactly these connected watches. Is this something you are using in Canada?
Yes. But yeah, so we are using mostly punctual vital sign monitoring, but we also try continuous monitoring, but sometimes it's more an issue because, for example, the sensor of the temperature was not working at 1 o'clock in the morning. So we receive a call for this. So now we are more on punctual monitoring for bispecific, but I think that it's something really promising and that will increase the safety, especially with CAR-T, where patients can have more CRS and complications.
Excellent, thank you. So it looks like it's a very, very exciting topic, and some colleagues are very enthusiastic. They're asking, can we do it at home? Is there any experience with bispecifics at home, Christine?
So so we haven't started yet, but I know like different centers. Right now, this is the first wave, right? First real world data as outpatient. So at home, I'm not sure because you need a chemo nurse to be present to give the drug. And if any of the home infusion can be arranged with the chemo nurses, that potentially a possibility with the nursing being there to observe them for some time. And I think we shall see if any infrastructure would allow that.
And Jean-Sébastien, same question to you, especially given, you know, the distances in Canada. That may be an option you may have considered.
We don't do it at home, but for some patients, we do it on like private clinics on small cities where we start the first dose here at the hospital, and for the second, the third, and all the other dose, the patients receive it in a private clinic, and we were doing like a video call with them the day of the infusions, and we were also doing the blood test on the private clinics. So that's the closer things that we do for now. But yes, I think it would be amazing if the patients can receive it at home and don't have to come at the hospital. Especially we did some elderly patients. One patient had 91 years old. So if you don't need to come 3 times on 1 week at the hospital, it can be really easier for them.
Excellent. So you mentioned that you are relying also on some local community, smaller clinic, hospital, just in case, you know, the distance is long. So that brings me to the question we also received from the audience, because we spoke about the role of the physician, the role of the nurses, the pharmacist. But Christine, are there any other members of staff? Exactly, because for instance, Jean-Sébastien mentioned the colleagues in the local hospital. Do you train, do you have programs, education, involvement of other members of staff, not directly involved in the program, but you would consider they can be involved at some point?
Yes, so for our center, we do have the social worker or case managers because their involvement is essential. Just like Dr. Clavo mentioned earlier, when you screen those patients, one of them is social status, social economical status, and whether or not this caregiver is feasible. So those are the things that we, of course, involve those team members. And then for the other satellite locations, this is a great question. We are actually exploring whether or not we can expand the program to those smaller, more remote satellite locations. And so we'll see if we have any experience to share. But I think that is feasible because one of the programs we are trying to work on is to educate community, because in US we have academic like university hospitals and also community practice oncologists, and then now we're trying to help them to establish their infrastructure. So those are smaller size and sometimes more remote, and we're seeing more and more community oncologists interested in setting up bispecific outpatient treatment in their centers. So we'll stay tuned.
Wonderful. Thank you all for joining. And we have a last question about the role of AI, but in when choosing and using bispecific. But this will take us beyond the scope of this discussion. I promise we'll have some dedicated activities from the ICH dedicated. And you may have noticed that we are already developing a chatbot dedicated especially to myeloma. The famous Dr. Richard we launched during the COMI Congress, the Controversies in Multiple Myeloma. Thank you both, Jean-Sébastien and Christine, for this insightful and very practical discussion. I think today's roundtable clearly highlighted that establishing an outpatient program for bispecific antibody delivery in myeloma and I guess this is also relevant for lymphoma and other diseases, is not only feasible, but also essential for optimizing patient care and healthcare efficiency, and with some thoughtful coordination between clinical teams, proper infrastructure, patient education, caregivers availability, but also risk management protocols, we can safely transition this innovative therapy into the outpatient setting. On behalf of the International Academy for Clinical Hematology, thank you to our two panelists. Thanks to all of you who participated, who joined us. And as always, I say, let's continue sharing experiences and advancing best practices to make these therapies more accessible to patients worldwide. This is the DNA of the ICH, hematology without borders. So wherever you are, please stay safe and see you soon. Thank you.
Thank you.
Thank you.